webinar focused on hospital triage of large vessel occlusions. Before we get started with today's webinar, I want to go over a few housekeeping items. To avoid background noise, we have placed all lines on mute. At the end of the presentation, if you'd like to ask a question, you can use *6 to unmute your line. All slides and a recording of today's webinar will be available and emailed to you within 1 week of today's call. We'll be posting them on our website, heart.org/SWA quality, if you'd like to view them there. For today is Dr. Jennifer Rasmussen. Dr. Rasmussen is a fellow-trained vascular neurologist. She is currently the stroke medical director of Baylor Scott & White Memorial Hospital in Temple, Texas, and Baylor Scott & White Round Rock Hospital in Round Rock, Texas. She serves as the Baylor Scott & White Central Texas Division Director of Cerebral Vascular Care. So I'm going to turn it over to Dr. Rasmussen right now.
And thank you, everyone, for coming to our webinar. Today, I'd like to talk about pre-hospital large vessel occlusion and sort of where the actual evidence is right now and where we think it's going to go to. I need to disclose, we are not going to talk about off-label use of medications. TPA, we already have the guidelines for, so we won't be discussing that in detail today. So let's start off with discussing why we even care about these pre-hospital triage for large vessel occlusion. We know that without intervention, this is a devastating stroke for the majority of our patients. The NIHSS stroke scale is greater than 13 and sometimes even greater than 17. It has a positive predictive value for living in a facility dependent on families and death. In addition to that, in our young patients, which we're seeing more and more strokes in the young, there is a high rate of mortality in these patients. Less than the age of 60, if they don't get neuro-intensive care management, including hemicraniectomy, the mortality rate is about 70 to 80%. In addition to that, it commonly comes from a new onset of atrial fibrillation. So these are patients that think that they're healthy, aren't really doing things that put at high risk. We're not monitoring them closely, and all of a sudden they develop AFib and they have these large devastating strokes. So we know at this time about revascularization with these large vessel occlusions. IV TPA is least effective in these strokes. Only 15 to 20% of them with IV TPA alone recannulize in 2 hours post receiving TPA. The average 90-day outcome is about a modified Rankin of 4, which means they're still disabled and they still need assistance with walking and ADLs. Acute endovascular trials that came out in 2015 have shown great success in changing this and making a modified Rankin of 2 or less, and making it the patients can be functionally independent. However, we still have a 6-hour time window on the majority of these patients, and most of them need IV TPA first. At this point in time, time still represents brain. We looked at Saver's article who quantified the analysis of the majority of strokes and how much time equaled how much brain, and he looked primarily at anterior circulation strokes. It looked like the majority of them complete within 10 hours, which equals per hour 120 million neurons lost, and per minute 1.9 million neurons lost. This is why we push so hard in our stroke centers to be efficient and quick in getting IV TPA, and also are pushing now as we develop more endovascular techniques to being quick and efficient with that. A sub-analysis of the REVASCAT data came out looking at how much did time matter for endovascular, because if you've gone to a lot of the ISC discussions, there's a big debate of does time matter, does time not matter, and where we actually stand with this. What we're able to show is that if their aspect score was already less than 8 at presentation, every 30-minute delay in reperfusion, they had a less likely to have a good outcome in these patients. So the majority of our patients that come in with these acute strokes that are large vessel, still time matters. Every 30 minutes matters whether that patient walks or doesn't, and how stroke goes on to complete. There is a subgroup where maybe time isn't the same, maybe their perfusion is different, they have good collaterals. It's a big area of debate, but it is a subgroup of a subgroup. And for the purpose of this talk, and for the purpose, I think, of developing systems, it's important to look at what the majority are. And the majority of these patients, time does matter, even with endovascular intervention. So we start to triage this. We all know the NIH stroke scale. And stroke scale looks at, 15 different elements. We're good at monitoring it. We know that it relates to the severity and size of stroke. But we come up with these different scales. So we evaluated the NIH stroke scale and looked at how many of them would predict a large MCA stroke. And I think something that's important to remember as we go through these different scales is that a large MCA stroke or anterior circulation stroke is really what they studied. We have almost no information on posterior circulation strokes. So something to keep in the back of your mind as we're thinking about these critical patients. Most reliable was language and then motor function of the arm and leg. And the least reliable was ataxia, neglect, loss of consciousness, or face changes. This is then further used to do subsets of NIH stroke scales to see whether those were reliable scales or not. A lot of that data is sparse, so we won't go into it in depth, but just to kind of understand that they looked back and they said how much do each of these components rely, and that's a lot of where we came up with the development of these different scales. The thing that's sort of interesting and kind of goes in using the NIH stroke scale is there was a study that came out in 2015 and it looked at helicopter EMT, and they looked at the positive predictive value of when the EMT arrived, getting them to a comprehensive center, what was the reliability of their NIH stroke scale and the amount of people that had a large vessel occlusion. And what they found is that 84% positive predictive value for large vessel occlusion with EMT demonstrated an NIH stroke scale of 12 or greater. Their full NIH stroke scale was highly correlated with a neurologist, which we've seen in the past that nursing and neurologists are also correlated, which is why we continue to use this scale. So while in a helicopter situation, taking that extra time to do the scale clearly proves that we have a good predictive value of whether or not there's a large vessel occlusion. That may be too much time for the average EMT on-site assessing your call-in for stroke. Now let's back a second and talk about the two predominant scales. For this lecture, I'm really going into what has been evidence-based, was published in the literature, not what we're seeing in abstracts, because that still hasn't been peer-reviewed. What is published and what are the two scales that have the most evidence? We'll talk about the Cincinnati scale and the LA motor scale predominantly. So the Cincinnati pre-hospital stroke scale was developed in 1999. It was developed to be a triage for the NIHSS trial. It used the major features that we already talked about in the NIH stroke scale as being reliable. So it looked for facial droop. Is there asymmetry? If so, you got a point. Arm drift. Could they not hold one arm? Was it not equal to the other? If so, got a point. And then speech. Was there something inappropriate in their speech? A point 1 on the Cincinnati pre-hospital stroke scale equaled concern for a stroke. And this was looked at with neurologists doing NIH stroke scale and ES doing repeated scales to see whether or not it correlated. We found that it had a good specificity of 87%. Stroke sensitivity was only 66%. Again, remember that most of this looks at anterior circulation stroke and excludes the things that we know are posterior circulation. And look at that also, anterior circulation stroke sensitivity was 88%, which falls in line with what we were trying to get with this and how it's evaluated. Currently, most of the nation uses this sort of scale as an EMS triage of is it a stroke or not to get them to some sort of certified center. So a study in 2009 came out, and they assessed what really was the sensitivity and specificity now that it's been 10 years in practice. And they found that there was a lack of specificity in this. And so instead of being in that 80th percentile, it's now 52% when we look back into our population of how it was actually being used. They went and tried intensive training to see whether it made a difference, and it didn't. And so one pushes was, is this a good stroke scale if in practice it's only 52% specific. Sometimes with looking at specificity also, not only do we not include posterior stroke scales or posterior stroke in this, but also mimics can bias one way or another. Interestingly enough, the Melbourne Ambulance Stroke Scale has been developed and isn't used here, which is why we're not going to it in depth, but it's very similar to the Cincinnati Stroke Scale. It looks at face, grip, and speech. They were able to, in Australia, show that at 3 years, it sustained a high level of specificity and sensitivity, which leads us to think, is this a training problem, even though that first trial tried to train better and didn't see an improvement, or is it a scale problem? The next scale that actually has come out from Cincinnati is the Pre-Hospital Stroke Severity Scale, CPSSS. If you look at it initially in reading papers, you will think that it's really similar to the Cincinnati Pre-Hospital Stroke Scale, but it actually is quite different. It looks for conjugate gaze deviation, loss of consciousness question failures, inability to follow commands, and inability to hold your arm up. This stroke scale was extrapolated from an NIH. So they went into the old data for NIHSS and IMS-3, and they looked at NIH stroke scales that were greater than 50, and they wanted it to correlate with the severity of stroke. And they went and applied it and found what their sensitivity and specificity of it was. This actually did include basilar strokes, and they found that a stroke greater than or equal to 2 was large vessel and occlusion, with a high amount of sensitivity, but still not very much specificity on this. It's important when you look at this to realize that this has been validated, but it has not yet been implemented. This is a retrospective review of data extrapolated from NIH, and it's not actually how EMS would use or interpret this score, but it is coming out as one of the leading scores and evaluations for large vessel occlusions. Now let's switch to the LA motor score. It was initially the LA Pre-Hospital Stroke Severity Scale. It was found to be highly correlated not only to the NIHSS, but to subgroups of the NIHSS, like that initial slide that we discussed. It correlates with stroke severity and modified Rankin at 3 months, and it's been repeatedly validated to be able to be given in less than 30 seconds, and so therefore does not have an impact on triage time and EMS procedures. It looked at facial droop. Is it absent, present, on drift, absent, present, severely present, and then grip strength as well. And see, we have these same sort of cluster of things in each of these scales of face, arm, grip, sometimes loss of consciousness. UCLA, the LA motor score is based out of UCLA. It was used for FastMag, and it had a lot of success in the trial as well. UCLA now has gone back and looked at their NIH, assigned the LAM score similar to how the Cincinnati Pre-Hospital Severity Stroke Scale was looked at. It looked at anterior circulation only, was there large vessel occlusion on imaging, median NIH of 14, so still these very high NIH stroke scales. And then saw at what point was the LAMS positive enough to indicate that it was a good predictor of large vessel occlusion. They found a sensitivity of 81% and a specificity of almost 90%. One of the things to look at this is it's also still not real life and how EMS is evaluated. The other thing to also remember when we look at this is that this data, by looking at what was discharged strokes from UCLA, excludes mimics, and that is part of the thing that may change our specificity on these patients. Borrowed this slide from their article because I thought it was a nice way to look at specificity and sensitivity, and if you can see right here, right before 4, where they cross, and they meet this point of almost 80 to 90% in both of them, and that's why I chose greater than or equal to 4 as their cutoff for it. So how do we apply these things? And this is where I think the discussion comes in. It's our proposed triage. You know, what are we looking for? Are we looking for large vessel strokes? Are we looking for who had a stroke or not? And I think it's important to remember the differences between what we're actually looking for with these scales. When we look at the Cincinnati pre-hospital stroke scale, it was designed to look for, is this a stroke, is it not? An initial MS triage of, do they need to go to a certified stroke center or do they not? The same thing, it's very similar to fast screening. What's the time, arm, face, and get them to a stroke center. That is still quite needed. We have drip and ship now, we have primary stroke centers, and we have comprehensive stroke centers. And the question comes, how do we then look for these large vessel strokes that really need to go to a comprehensive stroke center? I would suggest that not only do you initially screen for stroke, but then look at the LA motor scale or the Cincinnati severity scale, and you for severity. So does it look like, is it a high predictability that this is a large vessel stroke? If it is, then it may be worth the additional 30 minutes or helicopter call to bypass the primary stroke center and go to a comprehensive stroke center. When we know that every 30 minutes of delay increases the likelihood of a bad outcome from this kind of a stroke. As we talk about developing these systems, I think one of the things that's important to think about is also what is your premorbid state. And all of these, patients were able to walk at baseline. When we look at guidelines, it's important that patients can walk at baseline. That's who was included in our endovascular trials. That's what our guidelines recommend for endovascular care. So this scale, in combined with a good history of when were they last known normal and could they or could they not walk at baseline, is important. The question is, how will it impact our primary stroke centers and our pre-hospital services? So one of the fears I think that comes as a medical director of multiple primary stroke centers is, are we going to lose our volume? Is every patient going to go to a comprehensive stroke center? Is this going to be a huge burden on EMS? And we've been able to look at, when we look at the numbers of patients this actually applies to, it is less than 30% of our overall stroke population. The majority of our stroke patients have an NIHSS stroke scale that is less than 5%. So these scales are based on an NIHSS stroke scale of 15 or greater for most of them. So it's about how many patients come into your center that are actually a 15 or higher. It's a very, very small proportion of patients, and therefore it's not appear that it will be a big impact on our system. The study has actually looked at this. It's a Madrid study, and it looked at interhospital transfer. We found that 41% of their patients transferred from a primary center to a comprehensive center in the Madrid system did not end up receiving endovascular care. And I'm sure a lot of you stroke coordinators out there have experienced that, where you go through all this effort to transfer. It takes an hour and a half to transfer the patient, and then the feedback is you get that they did not get endovascular care. And it makes you feel like it wasn't worth the effort to do it. They looked at why. So they found that 48% of their patients revascularized or improved with IV TPA. They may not have improved back to baseline like they would have with endovascular, but they did improve. 32% of them lost their penumbra, so their aspect score dropped less than 7, and they were no longer an interventional candidate. They have, in this study, actually really fast transfer times, a median of 60 minutes, which is, at least in my system, would be a phenomenal transfer time for us to be able to have. There was a larger variance or wider confidence interval on the penumbra, poor outcome, no endovascular treatment patients with time. So it looks like there was more of delayed patients in there, but not enough to actually change the median, and there was no statistical significance between these groups. Then they looked at 3-month outcome with a modified Rankin less than 2. So that's what our goal is with endovascular, right? We want these patients to be able to walk, to have minimal deficit, and go back to their normal, healthy lives. What they found is patients that were at the facility when they determined endovascular care was needed, 61% of them went to a modified Rankin less than 2. Patients that were transferred and received endovascular, so ones that may have had good controls, good fusion, because they didn't drop that aspect score, 58% of them went to a modified Rankin less than 2. the patients that were transferred and did not receive endovascular care, only 40% of them went to a modified Rankin less than 2. And those are the ones that went and ahead and lost their penumbra, but also ones that looked like they were improving still did not have a high rate if you look at the 40% compared to 61% of good functional outcome at 3 months. And then of ones that were not transferred because their initial aspect score was less than 7, only 33% of them went to have a modified Rankin less than 2. The way I interpret this data is you look at it and you can see the amount of time and effort that goes into transfer, and you still don't get the outcomes that you would expect to get with the number needed to treat we know that vascular provides. And so it makes us think, or it makes me think, do we need to bypass primary stroke centers and go to endovascular centers if they're within a reasonable time window for these complicated scales, or for these complicated patients? Also then leads to the questions of what's acceptable with our misses and our false positives. If you look at the LAMS sensitivity and specificity, you still miss 20% of your large vessel strokes with this. You are very specific, almost 90% of the time accurate, but you still miss 20% of our population. And then you look at the Cincinnati stroke severity scale, and you miss also about 20%, but you are much less specific, which makes you wonder, does that mean that we're going to have an overutilization of transfer and hit to our system? I think in both of these cases, more studies are needed, and I believe are ongoing to look at actual implementation to verify the sensitivity and specificity. But as those studies are going on, we still have to start developing systems on what we think is best. Some of it relies on how easy is it to train your EMS, when are they comfortable with, and what timing it is. Race scale is what is often talked about. It has only been studied in one published study at this point in time, and is not one that I fall back on as being reliable and well validated, where these other two have been validated through multiple studies. And that's something to think about when we're also looking at scales. Here at Temple, one of the first scales that we were excited about was actually the MENS scale, and the MENS scale ended up with one patient, tons of abstracts, and then has totally fallen off of math. Which again is why when we're discussing this, I think you need to look at who has been repeatedly validated, how are they validating that before we start talking about implementation. It's important that we remember IVTPA is still needed first. If you're almost out of that IVTPA window, does that benefit at that time to go to a primary stroke and then transfer for endovascular? Are you almost out of the time where endovascular may not help you anyways? And I think those are discussions to have within your systems, and we don't really have good answers for. The other thing to think about is, how does it affect the burden and how your system works? Here in Texas, we have RACs, which are little regional areas, and it's a lot of effort to transfer in and out of a RAC. And so that starts changing how we move and transfer and think about patients. Last thing that I kind of wanted to talk about was posterior circulation strokes. This is a passion of mine, and this is the fatal stroke. These are the ones that we go to lawsuits over. These are the ones that leave people incapacitated, and you're trying to tell the family that even though they barely move an arm, they're not going to come back. While I think that anterior circulation strokes you live with, and you can live with major deficits, they still live and interact to some degree depending on which hemisphere. Most large vessel posterior circulation strokes, the patients are truly devastated. Our scales, especially our triage scales at this point in time, completely exclude posterior strokes. Our endovascular studies, the majority of them also excluded. And so it makes you wonder, what is the time frame? How do we approach that? And I think this is going to be the next forefront of where research occurs. An interesting study came out that showed that 22% of posterior circulation strokes are missed in the ED. And I know even here we've seen patients that are dizzy and walk a little funny, and we think they're young, that they're doing well. We send them home, and then a day later they come back with a stroke. In community hospitals, this number is even higher. It's 26%, compared to only 16% of anterior circulation strokes missed. Personally, this is an area of education that is needed, but more research should come out soon to help us with it. They look at what are positive predictive values of actual neurologic findings, and they found that, to say for sure when someone comes in with dizziness and other issues and nausea, is it a post-circulation stroke, that the most predictive signs would be a Horner syndrome, cross-sensory, hypoxia, or oculomotor nerve palsy. A couple problems with these, though. Very few of them are part of our NIH stroke scale and differentiation. Difficult findings even for some neurologists to find, and definitely difficult to train globally on. And they still have an overall low sensitivity for detecting these strokes. So more of how do we evaluate it broadly and how do we develop the scale, it needs to be looked at and worked out. Look at things that are on our major stroke scales. Hemiplegia, only 53% of the time is that positive in a posterior circulation stroke, where 75% time it's positive in anterior circulation. You look at facial movement and facial involvement, it's only 41% in posterior circulation stroke, 62% in anterior circulation. One of the ones that's similar between the two, but actually not very common, is your hemisensory. And that's about where we are with where the scales are and the overlap that exists between these two. And if you think back to that first NIH stroke scale of the least predictive large MCA strokes, the things that fell out were the posterior circulation stroke symptoms. It was your hemianopsia, it was your ataxia, and level of consciousness. All I want to open up for questions and discussions, because I think this is a topic that is green and is warranted for discussion.
You can press *6 to unmute your line.
Hi, this is Dr. Lee Birnbaum in San Antonio. Hi, Dr. Rasmussen.
Go.
I might miss this. Is there a interval of time that you think is or reasonable to get to the Comprehensive Stroke Center?
Yes, and it's for some areas like ours out here in Central Texas, it may even be 45 minutes, depending on the amount of transfer, but I think that at least 30 minutes evidence supports that it is worth the bypass.
In the question and answer section of WebEx, what are you seeing nationally as the time frame that most stroke centers are using in their definition of co-stroke?
Vary from center to center. Some places it's 8 hours, less than 8 hours. Some places it's less than 12 hours. Here we have less than 4 hours because I think it takes a good 30 minutes to come in and evaluate a patient to get TPA. Endovascular, we are opening up to less than 8 hours, although I have hesitation with that when you look at the trials, and that 6 hours seems to be a fairly strong cost for reperfusion.
Great. Any other questions? You can use *6 to come off mute, or there's also, you can type it in the question and answer section of the WebEx meeting.
I joined late, but will this be available?
Yeah, I'll be sending out a copy of the slides and then a link to a recording of the webinar.
Thank you.
You're welcome. In the WebEx queue, do you think the concern of the impact of primary stroke centers, sorry, my screen just moved. The impact of primary stroke centers is driving facilities to become comprehensive stroke centers?
Evidence yet that this is going to significantly change primary stroke centers' volume. I think that it's a fear that a lot of people have, but when you look at it, we're talking less than 30% of our stroke volume is an NIH greater than 5, and these scales are really looking for an NIH stroke scale of 15 or greater, and so I think that this is going to be a small population of our overall strokes, and hopefully would not affect our primary stroke centers and our drip and ship, which are all needed to treat strokes quickly and efficiently.
Come off mute and ask a question. Start to unmute your line. Has anyone heard more about the VAN pre-hospital screen? They're not sure if it's something that's used in the Arizona hospitals.
I've not heard of the VAN scale, so my apologies, and I didn't see anything published in the literature, although I may have missed it.
There are primary stroke centers with endovascular capabilities that may not be appropriate to be comprehensive stroke centers. What are your thoughts on bypassing them?
Good question. And the other thing that feeds into it are what about these centers that are becoming comprehensive and so they need the volume to make their systems work? There is an area that it's needed to develop more. Comprehensive stroke centers, what I think their strength is not only educating and working with their community, but also having a good, strong neurocritical care unit, which in these patients is likely important. The other thing that we're noticing as we're becoming comprehensive at the facility I'm currently at is that the timing of endovascular and the buy-in for the facility is really hard to get the numbers that we see in these studies for acute endovascular care. To get a patient in and to reperfusion in 60 minutes is incredibly tight, and comprehensive centers have reported repeatedly that they are able to do this, but I have doubts that a primary stroke center with a good endovascular team can. I know here we have issues as we're developing our comprehensive to do it. And those are things that I think need more debate and discussion, but there are standards for comprehensive that do improve, I think, patient outcomes, especially in these severe strokes.
Great. So we have more questions in the Q&A queue I'll go through. Do you think as more rural areas have access to telestroke that you will see improvement in the outcomes?
I think telestroke in rural areas is the way to get patients quickly assessed, especially for the majority of them that just need IV TPA. The question becomes then, how close is the closest comprehensive center? Are you in an area that actually needs to go to a primary stroke center first with a telestroke and then transfer out, or even go to one of our stroke-ready facilities? We have areas here in Central Texas that there is no way we can get them timely for assessment to a comprehensive stroke center, and to wait for a helicopter actually takes just as long as going and assessing them at the stroke-ready facility. So I think that as this develops, rural versus suburban versus urban are going to have very different triage policies, which is why I encourage you to talk with what your system is where you are when you design these policies.
Great. Looked at the European stroke scales at all?
If you have a specific one, I can tell you whether I've read something on it. I did look at the Australian scale at depth, and it looks to be a very solid scale, but I think it's hard to change what is already popularized in our system to go to another scale. And a lot of them are very similar in the components that they have.
question. All right. Will there be a requirement that endovascular center specialists are trained specifically for brain intervention?
I don't understand that question. Is there clarity to it?
Or if they then with another clarifying question on one. In the meantime, we'll go to the next one. Our hospital currently includes a CTR code stroke, and our stroke order set should be removed. Should be removed since our house is a primary stroke center.
No, don't. I think that when we look at the endovascular trials, some patients had an NIH of 6 or less, and they would not fall into these large vessel occlusion scales to be transferred to a comprehensive center, but would likely still benefit from IV TPA and an endovascular approach. So I think screening your patients for the lower NIH stroke scale is still warranted in most situations.
All right. Clarify the event for not considering the MIND scale.
And I was looking for repeated validated studies, and then has not been repeatedly validated or used in practice. I do actually think it's a very good score, but the evidence isn't behind it at this point in time.
Great. This one is specific to your facility. What scale are your pre-hospital providers currently using, and has race been looked at?
Using the Cincinnati pre-hospital stroke scale, we are debating between adding the LAMS versus Cincinnati pre-hospital stroke severity scale, although I have to say I think our preference will end up being LAMS. And then RACE has been looked at. It has one very well-designed study, and it was implemented. And I think that as more evidence comes out, it may become a contender, but at this point in time, it has not been validated in multiple settings.
Question, so let's put on our legal hats. In litigation, are you seeing more lawsuits filed for poor outcomes after endovascular procedure is done, for not getting patient to the appropriate center in time for the intervention that could be done?
So the litigation as well as I should, but I can say that when people I've known have been brought up for litigation, it has always been for not getting the appropriate care timely, not for getting excessive care.
Would you ask a question? You can use star 6.
Yeah, I'm calling from a primary stroke center. And I'm just curious, in your opinion, what volume of endovascular therapy is needed to remain competent?
It's a really tough answer. I think, in my opinion, I would say you need about an average of 1 a week so that you have a well-moving, smooth system, your ED recognizes it, your team comes in timely, but it hasn't been looked at highly, and it's really a little out of the scope, what at least I've investigated at this point in time.
Star 6 to unmute your line. Slides and a recording will be sent to you within 1 week of today's webinar. We'll also be posting them on our local website, heart.org/SWA quality. We'll off mute with Star 6 if you have any more questions.
This is Marilyn from Methodist Charlton Medical Center.
Hi, Marilyn.
A couple of things. Do you find that most CMS systems are using Cincinnati or LAMS? or one more predominant?
Most ones that I've worked with in Texas are using Cincinnati as a general screening for stroke, and they're moving towards LAMS for looking for a large vessel bypass. But I'm aware of anyone, at least in my region of Texas, not talking about Houston and San Antonio, which I'm not as involved with, that have used anything other than, that have actually implemented their bypass program at this point in time.
All right. Can I ask one more question? Could you specifically just elaborate on the highest predictive signs of the posterior strokes? I have a we were discussing that, so we were wanting to ask for you to elaborate on that.
That looked at the highest predictive signs for posterior strokes looks for what signs that you found that were able to tell you it's a posterior stroke. The problem is it had very low sensitivity. So it missed still quite a bit of strokes, but it looked at and found that, you know, cross-sensory findings is really only seen in a posterior circulation stroke, so it's not surprising that that came out. Horner syndrome as well, it's usually only seen in a posterior circulation stroke, so it's not surprising that that would be predictive of those strokes. Quadranopsia usually is found in a PCA, smaller thrombotic stroke, so again, not surprising that that came out. In my opinion, but not what came out in this study as highest predictive, the sensitivity and predictive symptoms of posterior circulation strokes are still nausea, ataxia, hemianopsia, and loss of consciousness in a portion of them as well.
Thank you.
Questions, you can press *6 to come off mute or use the question and answer section of the WebEx. All the questions that everyone's had so far. Next station. Another question in the queue. Are any studies looking at the BFAS scale to catch the posterior circulation?
I crossed those studies at this point in time. Again, I may have missed them. From my understanding, they've been in a lot of abstracts, and I think it is a very promising evaluation.
Questions from the phone line? *6 to unmute your line.
Hello, it's Patricia from California from Comprehensive Stroke Center. I don't have questions, but I do have a couple of just updates. Somebody was asking about sedation and volumes for neuroendovascular surgery. In the current edition of the Journal of Neurointerventional Surgery, there's an editorial. Dr. Linfante from in Florida, I believe, and there is promising new recommendations coming up for certification or neuromuscular trainings for and what is required. And also our hospital, we're part of Santa Clara County, and we're doing a study with the local EMS on BFAST.
Oh, great.
Various strokes. We're still collecting data with our local county EMS.
You're welcome.
That is good to hear. It is really needed. Thank you for that update.
You're welcome.
I have a question, again, came in late. Is of the Cincinnati Pre-Hospital Stroke Severity Scale. Are the components gaze, arm weakness, and level of consciousness, are those the three components?
Yes.
Okay. And it's a little bit different than the LAMS, actually. I was familiar with the LAMS, and so those are three. I'm correct on that. I just wanted to make sure I was correct.
What's interesting is not only is it different than the LAMS, it's also quite different than the Cincinnati pre-hospital stroke
Exactly,
scale.
yes, quite different.
And so it can be very confusing.
More like the LAMS way. Right, so, oh, interesting. Okay, thank you.
Great question. Anyone else? Star 6 to unmute your line.
I have a question regarding helicopter EMS. From that perspective, if you were at the scene of a stroke, basically coming from outside of any hospital, we suggest that flying to a comprehensive stroke center versus a primary stroke center, even if that primary stroke center is significantly closer, be advisable. If so, what's the line of time? If there's 30 minutes in between the primary and the comprehensive, or less, or even an hour, would it be worth it to go to the comprehensive?
It's a great question. So what's interesting with them is they actually did full NIH, and I think if you're doing a helicopter transfer, you probably have time to do that. And they were so on point with their predictability of large vessel occlusion that it is likely not only worth the 30-minute, but maybe even worth the hour. Because I'm assuming if you go to a comprehensive and they find a primary stroke that's closer, and they still find that large vessel stroke, you're going to have to then reload the patient up with TPA and transport them again. Nothing has actually looked at that amount of transfer time yet, but it is something that makes you wonder whether it's worth it. And I would tend to believe it would be, but I can say that there's evidence behind that yet.
Any others? Mute your line if you'd like to ask another question. Anyone? We have minutes left of our scheduled time. If there's questions, we can tackle those. Well, I just want to, again, thank you so much for presenting on the webinar today and answering so many of these questions that our attendees have had. I also want to give a special thanks to Lee Allen, the stroke coordinator at Baylor Scott & White Memorial Hospital in Temple, for helping us coordinate today's webinar. I think it's been a great success, and I love the conversation that we're having over this topic. One last call for questions. If you'd like to come off the line with star 6 to ask anything. Thank you everyone for attending. Dr. Jackson, thank you one more time for engaging with this great information. And we appreciate it, and everyone have a great rest of the day.